Hello. Can you hear me?
Yes.
Okay,
Hello.
great. Great, welcome. Thank you for joining. Sorry, I'm a little bit late. Let me share my screen, then we'll get started. Okay, hopefully you can see that. Welcome to our updates for May 6th. Happy Friday. Thank you for joining us and being flexible with your schedule. What you're looking at is actually going to be in the PDF that is sent to you. So check your email. You've already got these notes, and hopefully if you have any other questions, feel free to ask. And otherwise we'll just go forward. So in terms of our case statistics, this is kind of where we're at. We do continue to monitor very closely. We're at a very low level, but the level is creeping up just a little bit. Just that's probably the nutshell of what the number of total cases is doing. In terms of the number of total hospitalizations, that's summarized here, and the number of total hospitalizations keeps going down. So we're very happy about that. Currently, there's about 30 inpatients in our hospitals. And so that's something that we keep an eye on and continue to monitor. Here's our wastewater surveillance with COVID. So this is done with copies of RNA, and there's a concentration. I forget the units, but basically what you can see here, it's very subtle, but again, kind of an uptick. This is the Omicron surge, the big blue peak. And then we were doing really well. We had very low numbers in our wastewater, possibly small uptick starting. So again, nothing to panic about, not even close to surge levels, but it's there. So just to let you know, why is this happening? Well, there's probably a few explanations. First, we know that usually 10 days to 2 weeks after major holidays like spring break and Easter, and many of the gatherings that happened around that time, is when you start to see increased transmission. Second, all the masks are off, right? I mean, you probably can't even find a mask anymore at your own house or in your car, when before you had one on you all the time. So unless you're working in a clinical setting, no one's wearing masks out in the general public. And that's a little disheartening, because we know that there's a lot of immunocompromised people, there's a lot of vulnerable people, there's a lot of unvaccinated people, there's a lot of kids who are not eligible, and all of them are, for better or for worse, going to be susceptible to the virus circulating. And so we definitely, there's a lot of ways to explain why this uptick is happening. And then the third reason, which I'm going to talk about in a future slide, is that the variants just keep getting better, at spreading. And so we may be seeing more contagious variants that are driving some of this uptick as well. Again, probably not appropriate to sound an alarm that we're going into a surge. I feel like that would be a false alarm, but it's something that obviously our epi team, our data team monitor very closely, and we share information with other counties and with our state and federal partners on a weekly basis. So there's people that are watching this number very closely. So in terms of therapeutics, the big announcement is that really we're hoping to make a lot of inroads about how to make treatment more efficient. So as you'll recall, you've been hearing me harp about this issue for many weeks now, but basically we just have a kind of a gap with, trying to get treatments into the hands of patients that need it most. And we're not doing a great job at many different levels at making that happen. There's a lot of confusion. Some people don't even know that COVID is treatable now. They just think you have to fight it on your own. Other people may know about medications, but they don't think that they qualify. And then the third is, even if people want this medication and know that they qualify, there's a lot of confusion about how they can actually get it. All of this really hinges on testing. So we obviously, no one's going to treat COVID empirically. So you do have to have a test on file to qualify. And that testing is not always easy to accomplish, especially because home testing doesn't seem to be something that is universally accepted as okay to do for this. So then you have to have clinic-based testing or some other testing model. Well, the federal government and the state government have different ways to solve these multiple problems and hopefully make this more efficient. And all of them are called test to treat strategies. So you've heard about the federal test to treat strategy. It was something that the president really announced way back in his State of the Union address. It has yet to materialize in a way that satisfies everyone involved, but there is a test to treat program at the federal level and at the federal locator maps for each county. Now, it turns out that in our county of 1 million people, there's one test to treat location with that federal program. So it completely, underwhelming, as it were. We're happy that it's there. Hopefully it'll expand, but we definitely need more than that one location. And it's not even in a location that has a lot of equity issues. So it's unclear why they chose that location, but they didn't ask us. They just set it up. And if you look on the locator, you can find it. So that's the one test to treat location. So what can you do outside of that? Well, the state, remember, has a bunch of testing sites that they call the OptumServe sites. Those never really went away. So the testing sites called the OptumServe sites are basically, they're going to convert those into a test to treat site. And they didn't really give us a time frame. They just announced it this week at the state call. And they said, over time, hopefully over the next few weeks, they're going to pilot it in 5 different counties. Our county is not one of them. Then they're going to expand statewide. And then basically, this is the schematic that OptumServe actually created about what they're planning to do. So you can see here that there's going to be some registration. Then the patient's going to get a test done. And then they basically, if they have a positive result, then they're actually going to have kind of a medical care paradigm nested inside the OptumServe. And that's going to require a health screen and then a prescription screen and then dispensation, so that it's a one-stop shop for patients to go in, get tested, get screened, get counseled, and walk out with medications if they qualify for them. There may be a telehealth component to do the assessment and a telepharmacy component to help with the medication counseling. More to come about this. This is obviously a very high-level overview, as it says, but this is what they're planning to do. We have about 4 OptumServe sites here in Fresno County, so we will hopefully see those converted into test to treat sites. What can you do in the meantime? Well, there's a couple of other test to treat sites that are, I think that we didn't call them test to treat sites, but that's basically what happens. A good example is the UCSF COVID Equity Project. They're able to do testing and they're able to do treatment. They're able to do the monoclonal antibody treatment as well as the oral pill treatment. And so, but de facto, they are a test to treat site, even though they don't call themselves that. So that's one option. We just need more of these models popping up. We need more innovation in this space. And honestly, a lot of this can be done over telemedicine. There's no reason that you have to have the patient physically in front of you in order to screen them to see if they're high risk, in order to counsel them about the medication. And with the medication, remember, some of these medications have a lot of drug-drug interactions, especially COVID. And other medications have fertility issues, such as the molnupiravir. And so that requires some conversations with patients, but you can totally do that over telemedicine and then call in a prescription or authorize an electronic prescription for them to pick up the medication. So this is something that we just need more people to innovate in this space. And we're happy to hear your suggestions about how we can make this happen. The ideal situation would be, someone just takes a home test. If it's positive, they just go online and then they basically can just order the medications for themselves after filling out a health screen and a medication screen. And then the medication just is mailed to them and it arrives at their front doorstep. That would be the ideal. That's the most efficient way to do this. I'm not sure how to make that happen either, but that would be, until we get there, we're really all going to have to come up with some stopgap solutions, especially if if this uptick in numbers continues and we start looking at the possible onset of a surge. Then we'll really have to have this dialed in correctly, or else we will definitely have a surge. So I feel like even though this is a very simplistic map, even though this requires a lot of work to set up, it's really worth doing because this is our best bet that we won't go into a surge again, is if we get enough people to get access to the medications in time to keep them from getting hospitalized and to keep them from getting COVID to their friends and neighbors and coworkers. And I linked the federal test to treat site locator for you so that you can see, even though there's not a lot of test to treat sites in the county, there are a lot of pharmacies that have the medications. And so if you prescribe the medications, you should be able to find a pharmacy near where your patient lives or near where your clinic is that can actually hand out the medications. And that's all found on this link that's at the bottom left. We're also working on an update of our document that lists all of the monoclonal antibody sites. And the monoclonal antibodies, remember, are if the person doesn't qualify for oral medications, they may qualify for a monoclonal antibody. It's a one-stop shop kind of infusion. It's basically a one-time infusion of an antibody called bebtelovimab. That's the only one that's currently approved, given the variants that we now have. But you know, a lot of our antibody providers are ordering this bebtelovimab, and they're able to give it. So if you do need to refer patients, please look on that document to find clinics and other places around town that are doing that antibody infusion. What are the variants doing? Well, the BA2 continues to dominate. So we're still in the Omicron era, as it were. Remember, the original Omicron is this purple color, which is slowly over time becoming less and less. And the second Omicron was something called the BA2. And even though it didn't create the surge, it really just took over as the dominant variant for a while. Well, even that is now being crowded out by this third Omicron variant, which is now called BA2.12.1. And the very first case was reported this morning. My team told me about it. It was a woman who was vaccinated and boosted between the ages of 30 and 40. And whenever she was tested, she tested positive for COVID. And whenever the genomic sequencing was done, it showed this new variant, which is the BA2.12.1. And this is considered 25% more infectious than BA2, which was already super infectious and just took over as the Omicron variant that dominated the whole country. So it seems to be about a 75-30, 75-25 split with BA2, the original BA2 being the 70%, as you can see here in this clock diagram. And then about a quarter of cases, maybe 20% of cases are this BA12.1 in California. And in other parts of the country, it's really dominating, like region 1 over here, region 3.
Call 1.
Okay. And this is from the CDC. All right, something else that you need to know, and probably something that if you've been working clinically, you've observed informally, you're seeing a lot more patients with flu-like symptoms. We're hearing from all corners that this is happening. And every time we check for flu, we're actually getting a lot of flu A positive back. So there's a lot more influenza circulating right now. Here's some great statistics from our epi team, which shows that, this is syndromic surveillance, but this basically is influenza acute care visits. So in our emergency departments, there's a real rise in the last week or so related to influenza-like illness going up when it was pretty flat from February all the way to late April. And then really in the last week of April, there was a real shooting up of influenza-like illness visits. Whenever it's broken down by age, it really seems to be young people, ages 0 to 17, that is really driving this influenza-like symptom mini surge, as it were, but it's really 5 times the baseline rate. So it is significant. And then whenever we compared it to years past, there seems to be a signal there also where, again, Dr. Kokumar was able to highlight the sections in early May that we should compare to. Last May, we did really well. The May before that, in May 2020, we had a few days where we had this many numbers, but not that many. But here it seems to be a more significant signal, and it really goes over that 20, that case rate of 20 per day. And so this is another, all 3 of these are basically the same signal which shows that influenza, like illness and influenza itself, whenever we swab for it, are basically ticking up right now in Fresno County. There's a lot of inpatients that are now being diagnosed with influenza, and so this is happening. Be careful. This just means that it's not a bad idea to mask up whenever you're out in public, and definitely if you're symptomatic, even if you're COVID negative, take that seriously. If you're testing yourself at home and you end up COVID negative, it might be influenza or some other contagious illness. So definitely stay home and don't spread that to other people. And if you're worried about influenza, just go get tested, and then you'll know for sure. Hopefully, all of you are vaccinated against the flu, and that should protect you somewhat. This is not even flu season. Remember, flu season ends March 1st, so it's very atypical to have influenza at all during this time. We know that it does circulate throughout the year, but it's atypical to have this kind of an uptick. But it's happening for the same reasons that I laid out earlier on, which is the masks are coming off. We're having more gatherings, and this is another virus that takes advantage of people not having the immunity that can fight it off. And the fact that we've had 2 good years without a lot of flu means that there's probably a lot of people walking around without a lot of flu antibodies. And so this year might be the year where we see a lot of flu. Any questions or anybody want to add to that? And by the way, flu A, the H3 variant of the flu A, which is what seems to be dominating this whenever people look, is really not that susceptible to vaccines anyway. So it's like this is the one that always breaks through the vaccine shield for influenza. And so it's not really that surprising that this is the variant that is kind of ticking up. Now, this is not the same as the bird flu, which is another issue that people are monitoring. With the bird flu, there's lots of poultry that are exposed and susceptible. And unfortunately, it can cross over and cause avian influenza in human beings. There's only been one case reported that I know of, and it was in Colorado, of someone that was working with poultry and came down with avian influenza. So this is not what we're talking about. This is just good old human influenza that circulates every winter and every spring. And now we're seeing an uptick of it here in Fresno County. The bird flu is another, kind of more exotic disease that we're keeping an eye on. And I would love to learn more about it for anyone who's on the call that knows more about it. But the CDC has put out an advisory about avian influenza for poultry workers. So for those of you that treat poultry workers, we do have, obviously some poultry factories and things like that here in Fresno County. So it's not unheard of, but for the most part, it would be really extraordinary to have avian influenza unless there was an outbreak of the bird flu locally, and I don't know of any such outbreaks at this time. All right, lastly, on infectious diseases, this is a checklist that Dr. Zweifler, Dr. Al, and our communicable disease team was able to put together. And this is basically about MDRO, so multi-drug resistant organisms. So these are bacteria that are real pains. They cause big headaches, and they're quite dangerous for our patients and for our staff because they're very hard to treat and eradicate. So what we came up with was a checklist for nursing homes to make sure that their high-risk MDRO patients are well cared for and that the infection itself doesn't spread to staff or other patients. This is a checklist that's going to go live very soon. I think it's being finalized and formatted, but I just wanted you to have an early look at it. This is going to be, again, for nursing homes. Voluntary adoption will be monitored. Voluntary adoption will be monitored and documented by having the director of nursing or the infection preventionist submit a statement every 6 months indicating that the SNF is complying with the expectations for high-risk MDRO patients to the extent possible. And it's consistent with CDPH guidance. And here's the checklist. So there's a checklist for patients, checklist for the room, and checklist for transmission precautions. Whenever patients leave facilities and come back to facilities, you want to make sure you're screening people, that you're pairing people up with roommates that can be co-located if they have the same MDRO, and that you're communicating with hospitals and other clinics, et cetera, that there's an MDRO patient that they're going to be either accepting or discharging, so that everyone's on the same page about what's being done, so that we're not really contaminating one facility with another facility with another facility, because these MDRO cases can be very resource intensive, very hard to eradicate, and quite dangerous for the patients. Okay, there's a lot of different ones. Like you can see all of these letters, it looks like an alphabet soup, but these are all different variants of MDRO, depending on which bacteria have it. So there's literally dozens of these now that are being isolated in California. And so you can read more about it through this checklist. I refer you back to the excellent talk that Dr. Al gave on this topic, which should be archived in our website. And so you can hear his whole lecture about this. And hopefully this checklist will be a good tool for our skilled nursing facilities to stay safer whenever it comes to these MDRO organisms. Please work with our staff. The final line of this is to report to the County Department of Public Health, and our communicable disease staff is here to help you troubleshoot and make sure that you're keeping patients and staff safe, so that if we need to come to a site visit, we're not the state, we're not JACO, we're here to help you, and we're here to just provide technical assistance about how you can get this done and keep your facility as safe as possible. So please utilize our resources, and we're happy to help deploy them, because we all need to work together on this very important topic. All right, couple of more viruses. So I already touched on the avian influenza. So I just put out the CDC advisory, which came out late last week, about that gentleman in Colorado who had it. And it's called H5N1 or bird flu. So you can read more about this, and I'll try to send out the hyperlink to it as well if you need it. The other one that we really need to all be very cognizant of is measles. So I would bet money that by the end of the summer, we're going to see a measles outbreak somewhere in California and possibly here in the Central Valley. And that's just because we've had several close calls already. And we know that we have a lag in people getting their vaccines for their kids, so that we have a lot of unvaccinated kids who may be susceptible to measles now. And unfortunately, it's just a matter of time before this really erupts into a case, and for that case to actually create an outbreak, because measles is really the most contagious virus that we've ever had. And it's like 20 times more contagious than the original COVID. So we're basically just, it's a ticking time bomb, in my opinion. Get to know measles. This is a nice one-page flyer from the CDC. I'll send you a hyperlink to it as well if you need it. But basically, this tells you what to look for. Really be on the lookout for rashes that are very concerning, especially in toxic appearing children. And it's, as you'll recall from medical school, it's a head to toe rash. It's maculopapular, and it spreads downward from the head and face to the neck, trunk, and arms. And it can cause complications, but really it's so contagious that you need to isolate these patients and really treat them as a very contagious case until proven otherwise. And more importantly, you need to send off the right testing. So if you get in touch with us in real time, we will advise you on how to do it. But we basically need a nasopharyngeal swab for PCR and a serum IgM for measles. And we can help you walk through this whenever you have a case. So communicate with us, but make sure you get that testing done before the patient is discharged. Hopefully they're well enough to discharge, which is fine to do, but you do need to get that testing done so we can make sure that it's not measles. Otherwise, we have to bring the patient back and then risk your staff again whenever we bring them back for testing. Okay, so just a quick refresher on measles. We'll probably do a deeper dive on this in future weeks whenever we meet again, but I just want to put this on your radar so you can be reading about it and have your questions answered. And CDC has great information on both bird flu and measles, and really everything else. They have wonderful resources that you can look at, including flyers for patients, flyers for your staff, and ways that you can get refreshed on these topics. Just a few miscellaneous updates, and then we'll get to the chat. As you know, the opioid epidemic continues to rage. It's at a point now where I actually did a Narcan training for high school students, and we ended up giving them free Narcan to take home. And the parents, we told the parents, and the parents were just grateful that we were doing it because everyone is terrified out of their minds. So Narcan is very easy to give. I keep some in my desk just in case we need to hand it out to anyone. But basically, you should know and be familiar with how to use Narcan. Hopefully, you could see that. It's basically an intranasal supply, and you just push the plunger, and then you deliver Narcan to someone who's in a coma, and you can wake them up. Sometimes you need multiple doses, especially with fentanyl. So each box comes with 2 doses, and we were able to distribute boxes out to high school kids. The reason that I'm bringing this up is because not enough people know about the threat of fentanyl, just how dangerous it is. You know, high school kids, because they're adolescents, they always like to push their boundaries and experiment and kind of break the rules. And while all of that is normal development, fentanyl doesn't forgive. You know, so this is not something that you really want to mess around with, and we need to get that message out. So for all of us who work with kids and teenagers, we just need to explain to them fentanyl is a real danger. This is really like playing Russian roulette, and it's found in all kinds of street drugs now. It's mixed with meth, it's mixed with Xanax, it's mixed with, whatever else people are buying off the street. So it's just contaminating any street drug that people access. And that's why we're seeing an epidemic of fentanyl-driven deaths in this country. And unfortunately, we're actually seeing teenagers dying in Fresno County from fentanyl. So we have the Fentanyl Awareness Day next Tuesday. You're going to see a lot of media and interviews and messaging related to this. But hopefully you can start to learn about this issue and be part of the solution by counseling your patients, by letting them know how dangerous it is, and really by referring people into recovery who need it. So, there's the pool of people like the teenagers and the young adults who have never been on opioids and should never get on opioids, and they just need to avoid it altogether. And then there's a pool of people who are unfortunately addicted to opioids, and then they just can't stop. They're not the same pools of people. The people that are addicted to opioids have to taper down very carefully and usually start something else that helps them stabilize their withdrawal, or else they're not going to do well. And those are the people that we can treat with our Bridge program at the Community Regional Medical Center, and with some of our outpatient programs that our behavioral health partners are running. But we can help you, learn about those if you want. And I'll probably dedicate a whole hour in future weeks to all about addiction medicine updates, because I think our whole medical community needs to understand what's at stake and what can be done. And there's actually a lot of good news there, is that, for patients that are addicted to opioids, there's a lot of resources available with clinics, with outpatient help, and really all of us can be more involved if we all get our DEA X waiver. And I can actually show you how to do that in a later time. I'm not going to do that today. The next thing is naloxone distribution. So again, this is a state grant. They will send you thousands of units of naloxone for you to become a distribution site. So we've done this with our hospitals. Community Regional is a site. Clovis is a site. Our health department is a site. We need more clinics to be doing this. We're actually at a point where they're handing this stuff out at rock concerts just because they need to get it out into the public. And it's just kind of a shame that, we don't have more clinics being distribution sites for this life-saving medication. So please consider doing that. It's a 2-page application. It's completely free, and it's really easy to do. And we can walk you through that application if you want. So please become a distribution site for naloxone. It's something that your patients will thank you for it. I guarantee it. Everyone's worried about this issue, and the more that we can do to help save lives, the better. And we know that naloxone saves lives. Another miscellaneous update is that we, through our STD testing division, we actually have a little bit of grant money left over. And believe it or not, because this is the way state bureaucracy works, we have to spend the money or we're going to lose it by the end of June. The reason that I'm sharing that with you is because we feel like we can actually create local grants to help spend this money down to do STD testing. So if you're at a clinic or even at a hospital where you need more STD testing done, either money for reagents or really, you name it, anything related to HIV, hepatitis C, syphilis, gonorrhea, chlamydia, if you just need, more funding to help make that happen for your patients, please reach out to us. We do have funding available and we have to spend it in the next couple of months. So we want to hear from you about how we can help do that. The next update is really something that we're monitoring and that something I'm trying to learn more about, and that is clusters of hepatitis. So there's one cluster of hepatitis in children, which seems to be related to adenovirus. CDPH is reporting about 9 or 10 kids that have kind of fit this criteria, and 2 of them have already required transplant. So it's not just a benign hepatitis that gets better. This can actually turn into a fulminant hepatitis where the kid goes into full-blown liver failure. And then there's 2 kids in California that have actually had to get a transplant in the last couple of weeks as a result of this. So, if you do see something that fits this picture, please reach out to us. We want to help you. We want to help work with the state to get the investigations done and to make sure that these kids are getting the best care that they can. Adenovirus testing can be done in serum, in blood, and even in liver biopsy, but it's not something that any of us are super familiar with because it's not something that we do every day. So there's a lot of help in technical assistance that we can bring to bear if you reach out to us about if you have a child that has increasing LFTs basically with gastrointestinal symptoms, nausea, vomiting, diarrhea, jaundice, abdominal pain, liver fullness, etc. And you ruled out other causes of hepatitis, which are still more common, like, for example, acetaminophen toxicity, other medications, etc. Then you may be dealing with one of these cases. Please reach out to us and we can help you get the reporting done, but more importantly, help take the best care of that child, given that this is a very rapidly evolving situation and that there may be cutting edge treatments that you need to know about. And then the second hepatitis issue is actually a cluster of foodborne hepatitis. This is hepatitis A. So this is the good old viral hepatitis A. It is a kind of a fecal oral pathogen, and it can cause foodborne epidemics. These can be very large epidemics. There can be hundreds of people involved. So the state works very aggressively to nip this in the bud. There's actually a foodborne cluster that is being discovered and worked up in San Diego, where at least 7 patients have been identified, but we know that many more are probably involved, and this could be statewide or even nationwide. So that's why we're putting out early feelers, just in case you start to hear about something like this, where, again, people show up with hepatitis. And this is not just kids, this can be adults as well. And then if you do the viral hepatitis testing, it comes back positive for hepatitis A, then you may be dealing with one of these foodborne hepatitis clusters. There's always a first case. So if you have that first case, and especially if you have more than one case because a whole family is involved, then definitely report that to us. And I don't know if Dr. Kumar is on, but she's going to be doing a whole presentation about this. So hopefully we'll have the opportunity to hear from her, talk about this in depth in a couple of weeks. But if there's anything else that you want to share right now, please go ahead, Dr. K.
I think that covered a good summary. There is a presentation on Monday that anybody is welcome to join if they would like on this topic, as well as some other emerging issues such as the avian flu will also be talked about. So I will link up that invite in the chat, and it is open to anybody.
Great. Yeah, that's a great meeting. Is that the meeting that was formerly called the Emerging Infectious Diseases
Yes,
meeting?
it's formerly Emerging Infectious Disease, but we have moved it into the Central Valley Emerging Issues in Public Health Consortium. So all are welcome and
Okay,
encouraged
great.
to come. We do want more participation.
And that's like a monthly meeting, usually on Monday afternoons, right?
It's quarterly on
Quarterly.
Mondays. Yeah.
Got you. Okay, great. Well, yeah, please share the link in the chat. I think that's fantastic. Thank you so much. And last but not least, we have our partners at Valley Children's Hospital and the Safe Kids Coalition helping to organize a Kids Safety Day out at Millerton Lake with the state parks. So this is going to be a super fun event. Really, all families are welcome. It's free. Parking is free as well on Saturday, May 21st from 10 to 2 a.m. And they're going to be talking mostly about water safety, because this is the time of year where, as the weather warms up, people start going swimming in the pools and the rivers and the lakes. And unfortunately, we do start to see drownings around this time, and especially after Memorial Day weekend. So we do need to be thinking about water safety. In the last hour, I was able to talk to Mary Jo Quintero with the Safe Kids Coalition, and she shared a great ABC mnemonic. So the ABC is keep kids at arm's length and make sure you can always get to them as soon as possible, especially if they are drowning in the water or slipping into the water, etc. The B stands for barriers. So make sure you have a fence around your pool and that it's latched, locked, gated, and definitely secured. So it's not just important to have a fence, it's important to have the gate closed at all times. And then the C stands for classes, swimming classes as well as CPR classes. Make sure that your parents, the families that you see, the parents know about swimming classes, and that they know how to do CPR. And those are available around town at many different areas. Many gyms offer swimming classes. Fresno State has a swimming class program. Many high schools even do it. So make sure that, if you deal with families where they have young children and they do like to do water activities or have a pool in their own home or even in their neighborhood, that we're doing everything we can, because this is absolutely positively the worst thing that happens to an emergency physician is having to deal with a drowned child. It's really one of the worst days. And then having to talk to that family, and really whatever we can do to prevent any of these from happening this year would be fantastic. All right, that's all I have. I'll go through and check the chat, and happy to hear from any of you if you just want to unmute. Yeah, lots of good announcements in the chat from our communications team. Thank you, Sim. And the Kids Safety Day poster is posted as well. So feel free to share that with your staff. It sounds like a great day on a Saturday out at Millerton Lake. And like I said, it's totally free. And there's really no capacity limits. They have lots of activities, and people can even get their life jackets refurbished or renewed if they trade in an old life jacket for a new one, if they need that. And this is really interesting. The hepatitis cases just keep mushrooming, as we suspected that they would, but now it's up to 100 cases across the country in the last 7 months. So it's probably been circulating for a while, but definitely something that's getting more attention, both nationwide, statewide, and around the world. Any other questions or comments? Everyone's quiet today. I want to start their weekend. All right. Well, I think we can go ahead and adjourn. If there's no other questions or comments, please keep up the dialogue. Keep sending us your questions and suggestions, and we hope we can reconvene in a couple of weeks. And in the meantime, we'll share updates over email. And like I said, we're working on several different health alerts, one related to influenza activity, one related to the MDROs, as you saw, and probably another one related to the hepatitis clusters and how you can do monitoring for those. And we'll continue to keep you apprised about updates and important information. Thank you all so much. Enjoy the great weather and have a great weekend.
Great, thank you.
Thanks.
Thank you.